This is Davierwala. Today I would like to give the readers an overview of the role an endocarditis team plays in the management of patients with infective endocarditis. Infective endocarditis is a life-threatening disease with a very low prevalence of ranging between 3 to 10 episodes per 100,000 person years in different surveys, being very low in young patients but increases dramatically with age, reaching a peak incidence of 14.5 episodes per 1,000 person years in patients aged between 70 and 80 years. It is a very complex disease that commonly occurs in patients with pre-existing cardiac disorders such as valvular or congenital heart disease. It may present in its simplest form, at least initially, with vegetations on the valves or myocardium, but can very soon result in the development of complications, either locally through direct extension of the infection into the annulus and periannular tissues, or systemically due to embolization with or without multi-organ involvement. It can produce myocardial dysfunction causing septic cardiomyopathy and heart failure, or can be associated with the development of sepsis or septic shock. The aggressiveness of the disease is dependent on several factors, the most important being the type of causal organisms, the immune status of the patient, and the presence of significant comorbidities. Therefore, local extension, systemic spread, and multi-organ involvement that is commonly observed in patients with infective endocarditis makes therapy challenging for a single healthcare provider. Another factor that also plays a key role in determining the course of the disease is the delay in referral of patients to specialized centers, which precludes them from receiving early surgery even when indicated. Due to multiple factors and organ systems being involved, a high level of expertise in various fields of clinical medicine is required to manage these patients. A patient commonly presents himself to a primary care physician who is the first healthcare provider in the food chain of management of infective endocarditis. Following careful recording of the patient's history, symptoms, and a physical examination, the patient with a suspicion of infective endocarditis is referred to a cardiologist who has the onus of establishing the diagnosis and initiating the management. Radiologists have a role to play throughout the pre- and post-operative management of patients with infective endocarditis. Diagnosis itself requires the use of multiple imaging modalities such as echocardiography, MRI, whole body CT scan, and occasionally nuclear imaging, depending upon whether the patients present with the suspicion of native or prosthetic valve endocarditis. Even in patients that are conservatively managed, serial radiological investigations are sometimes required to assess the progress of the disease and its response to antibiotic therapy. Microbiologists and histopathologists are necessary not only in identifying the infecting microorganism in blood cultures, but also in determining those existing in valve or myocardial tissue samples procured from the operating room. The first and foremost role of the cardiac surgeons is in the decision-making process with respect to the indication and, more importantly, to the timing of surgery. Infectious disease specialists are the best physicians to implement the most appropriate line of antibiotic therapy based on blood and tissue culture and sensitivity reports and patient comorbidities such as renal and hepatic dysfunction. A host of other specialists such as nephrologists, hematologists, neurologists, general and vascular surgeons would also be required in the decision-making process in special situations. Therefore, a reference center should have an endocarditis team that includes physicians from all these specialties with all the mentioned facilities for investigation on site. And finally, it is important to emphasize that early involvement of cardiac surgical team, even in patients deemed appropriate for conservative therapy, is extremely important for management of these patients. The so-called heart team concept has been in use for the management of coronary artery disease, structural heart valve disorders, and heart failure for the past decade with great success. A similar concept that has led to the development of the endocarditis team for the management of patients with infective endocarditis has also had a great impact on the outcomes in this patient population. A group from Marseille has demonstrated a reduction in 1-year mortality by more than 50%, declining from 18.2 to 8.2% after the establishment of the endocarditis team. Two groups from the London-based hospitals identified the inception of the endocarditis team as a significant independent predictor of 1-year survival even in conservatively managed patients. They revealed an increment in 1-year survival from 42.9% in the pre-endocarditis period and 66% in the post-endocarditis period with a hazard ratio of 0.2. The current ESC and AHA guidelines for infective endocarditis have provided a Class 2A recommendation for the establishment of a formal multidisciplinary endocarditis team in tertiary reference centers, because such a team requires the integration of experts from diverse medical fields for implementing appropriate care. The endocarditis team has many functions which are important in improving the overall care of patients with infective endocarditis. The clinical role is of primary importance. Definitive policies based on national and international guidelines and recommendations should be laid down by the endocarditis team to promote a standardized management strategy that will translate into high-quality diagnosis and treatment of the patients with infective endocarditis. The physicians involved with the endocarditis team should meet on a regular basis to discuss the line of management of new patients and referrals and the ongoing therapy of patients already under treatment in the hospital, to formulate a follow-up plan for patients prior to discharge, to implement new policies or changes in management based on new guidelines or important studies, and to improve communication and relations with major referring hospitals and clinics. It is extremely important to set up a seamless communication between the infective endocarditis team at the Cardiothoracic Center and the referring institutes. The most referring centers do not have specialists that have an adequate experience in managing patients with infective endocarditis, and therefore it is difficult or impractical to initiate comprehensive specialist endocarditis care in such hospitals. It should be easily possible to establish contact with them either by email or telephone during work and after work hours. In today's day and age, when information technology is easily accessible, telemedicine tools that enable quick sharing of diagnostic imaging and laboratory tests should be made available between the endocarditis team and as many referring centers as possible. The endocarditis team should prepare a draft that clearly states the criteria for the transfer of patients to the reference center. Any patient with a prosthetic valve endocarditis or infection associated with intracardiac devices or catheters should be sent to the reference center sooner than later. Patients with hemodynamic instability, acute heart failure or cardiogenic shock that is commonly caused by acute severe valvular regurgitation or significant intracardiac shunts due to endocarditis require emergency surgery to correct the acute mechanical problem and should be immediately transferred to the reference center. Intracardiac or periannular abscesses can potentially precipitate intracardiac shunts or extracardiac rupture or severe paravalvular regurgitation that can lead to sudden hemodynamic instability. Patients who are unresponsive to antibiotic therapy and those presenting with highly virulent organisms such as Staphylococcus aureus, fungi, etc., are at a risk of developing local and systemic complications. Such patients require urgent surgery and should be moved to the reference center as soon as possible. Presence of large vegetations and occurrence of other complications such as stroke, recurrent embolism, renal failure, and multi-organ involvement are usually surrogate markers for severe and advanced disease. Every effort should be made to operate such patients as soon as possible. Once the patients have been transferred to the reference center, it is the responsibility of the endocarditis team to discuss the complex cases and make decisions regarding the further line of management based on indications and contraindications for surgery, the optimal timing, and the type of surgery if necessary. Determining the type and the duration of antibiotic therapy to be administered is one of the most important duties of the endocarditis team. the time and the necessity of other surgeries that may be essential to treat either the focus of infection, for example, psoas abscess, vertebral body abscess, or embolic complications of endocarditis such as splenic, renal, or cerebral abscesses, are also the prerogative of the endocarditis team. Apart from this, the infective endocarditis team should ensure that a proper plan has been drawn out for patients following discharge. This is especially imperative for patients who have been conservatively managed due to the risk of progression of valvular disease. Besides, operated and medically managed patients have the greatest likelihood of developing residual or recurrent endocarditis within the first 2 years following the most recent episode of infective endocarditis. There should therefore be a follow-up setup with a cardiologist, usually with a specialist valve clinic at 3, 6, and 12 months after discharge, and thereafter at a frequency appropriate for each patient. Patients should also be educated regarding oral and skin hygiene and preventative dentistry. They should also be informed and educated about endocarditis prophylaxis and early detection of recurrent infection, which could potentially reduce the risk of development of deadly complications of infective endocarditis that commonly occur due to a delay in the initiation of appropriate therapy. Another important function of the endocarditis team is to arrange for rehabilitation of patients who develop endocarditis due to persistent drug abuse. A clear concept should exist regarding the management of recurrent infections in such patients. A second important function of the endocarditis team is education. It should ensure that endocarditis as a topic be a part of the curriculum in medical schools. A series of lectures ought to be conducted for medical students by various physicians involved in the endocarditis team. Additionally, bedside teaching and visit to the operating rooms to observe surgeries for infective endocarditis would help in leaving a lasting impression on all students, irrespective of the specialty they choose to pursue in the future. Continuous medical education courses and seminars should be organized for community physicians and other healthcare workers in an attempt to standardize practice in the community for the management of such patients. They should be aware of the fact that the diagnosis of infective endocarditis requires a high degree of suspicion, as patients may directly present with complications of infective endocarditis, which may make the initial diagnosis confusing and misleading. They should also be well informed about the type of patients who are at a higher risk of infective endocarditis. It is extremely important to stress the importance of the methodology of performing diagnosis, such as obtaining blood cultures prior to implementation of antibiotic therapy. And finally, community physicians should be made aware of the importance of the antibiotic prophylaxis, especially in high-risk patients and those who have already undergone medical or surgical treatment for endocarditis. Another important responsibility of the endocarditis team is clinical research. The team should participate in the development and maintenance of clinical data registries on patients with infective endocarditis. Various teams from the main reference center should ensure collection of uniform data to evaluate specified clinical outcomes that serve one or more scientific, clinical, or policy purposes. Registries can be used to determine the indications and optimal timing of surgery when required, the appropriate antimicrobial therapy for complex infections, and in comparing different modes of therapy. This would result in the quality improvement, clinical research, benchmarking, and also directly help in developing different payment and reimbursement schemes and models. Organizing and participating in mortality and morbidity meetings is extremely beneficial in terms of healthcare quality and safety and improvement. They are particularly favorable for building teamwork by focusing on constructive criticism rather than accusation. Additionally, such meetings are also very educational for residents and early career physicians. Such meetings also provide the basis for policy changes within the hospital community. Antimicrobials can eliminate sensitive microorganisms in blood but cannot penetrate vegetations, abscesses, and prosthetic material, especially the biofilms that develop on the latter. Delaying surgery could potentially increase the risk of developing local and systemic complications. Surgery plays a key role in such situations because it eliminates the sources of embolism, eradicates all infected tissue and prosthetic material, exposes residual microorganisms to antimicrobials, and restores valve function and structural integrity of the heart. Nevertheless, the definitive cure of infective endocarditis following surgical treatment is still dependent on antimicrobial treatment, which involves microbiologists and infectious disease specialists. Once the decision in favor of an operative procedure has been made, surgery should be performed sooner than later. Hence, delaying surgery in hemodynamically stable patients with adequate antimicrobial therapy and an established indication for surgery only increases the risk of embolization or local extension of the infection and is therefore not associated with additional benefits. Mortality rates are higher in cases of delay in surgery but may reduce significantly if surgery is performed as soon as the indication has been confirmed. Therefore, one of the most important functions of the endocarditis team is to prevent the development of such complications by determining the optimal timing of surgery. Cerebral embolism is not a contraindication for early surgery. However, it is recommended to delay surgery for a period of 4 weeks in patients with intracerebral hemorrhage when possible. A neurological or neurosurgical opinion is certainly useful in such situations. Hence, a multifaceted endocarditis team would provide better comprehensive patient care than one or two physicians from a single specialty working in isolation. Definite surgical indications have been laid down in the current guidelines for the management of infective endocarditis. The only indication for carrying out an emergent operation is in patients presenting with heart failure with evidence of pulmonary edema or cardiogenic shock. All other patients presenting with locally uncontrolled infections, infections caused by virulent microorganisms, persistently positive blood cultures despite adequate antimicrobial therapy, large aortic or mitral vegetations, persistent tricuspid vegetations with recurrent pulmonary embolism, or right heart failure with severe tricuspid regurgitation and poor response to medical therapy are candidates for urgent surgery. Radical resection of all infected tissue and prosthetic material is the main principle of surgery in these cases. The vast majority of operations involve straightforward valve excision and replacement, which can be performed by most trained cardiac surgeons. However, patients with complex advanced disease such as aortic root abscesses with involvement of adjoining structures and rarely the fibroskeleton of the heart requires highly experienced and skilled surgeons capable of performing complex reconstructive surgery. Furthermore, management of such complex disease also requires highly experienced and knowledgeable anesthesiologists and intensivists capable of treating patients with acute decompensated heart failure, sepsis, septic cardiomyopathy, who in addition have undergone prolonged complex operative procedures. Repair is preferable to replacement, especially for mitral and tricuspid valves, but decision making regarding repair or replacement may be challenging and requires extensive experience. Careful judgment needs to be exercised when delaying surgery to potentially increase the possibility of repair as opposed to performing early surgery with valve replacement. Early surgery reduces the risk of periannular extension of infectious process and or development of heart failure. Prolonged delay in surgery to increase the probability of repair may be counterproductive in certain clinical scenarios and could enhance the risk of irreversible heart damage. The type of prosthesis, mechanical or biological, does not affect survival. However, the use of homografts in aortic position in patients with aortic root abscesses usually is associated with better freedom from recurrent endocarditis. So to summarize, infective endocarditis needs multidisciplinary care as it enables an early diagnosis, expedites the decision making with respect to treatment, and provides comprehensive management, thus reducing the still unacceptably high mortality and morbidity associated with this disease. Implementation of such a concept requires a collective effort to optimize communication pathways, to favor inter- and multidisciplinary approaches, to enable outpatient treatment, and to strengthen community educational programs and medical training. Finally, I would like to thank you for your attention.